Good evening, everyone, and welcome to the August meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller, co-leader of the chapter, along with Dr. Amy Cipolla, who is also here this evening, and she's managing our tech for the Zoom call. We're excited to be hosting a talk this evening by Dr. Anna Bausum, ND of the Winship Cancer Institute of Emory University. And for reasons that will become clear very shortly, we think this presentation is going to be of great interest and relevance to anybody working to expand or even establish integrative oncology or general integrative medicine services in an academic institutional setting, but also will prove useful for those laboring to do so in independent practice settings. So I think this is going to be a really compelling talk that's going to have a lot for everybody. And I'll say one sentence about Dr. Bausum has been instrumental in creating and developing Winship's Integrative Oncology program. And you're going to hear more about her and her presentation in just a moment. I just want to take 1 minute before we get started, though, to note that this is the Cleveland chapter's first meeting since last November. And those of you who subscribe to our usually monthly newsletter and who follow our activities at all are likely aware that this is the first time there's been such a gap in our mostly monthly event schedule in the more than 5 years since we've had the chapter. So I'm not going to take up time to recount the reasons for this gap. They're mentioned in the month's newsletter if you want to take a look. But I do want to note that we're really happy to be back, and we do have a full roster of events scheduled, or at least projected through the end of the year and into next year. And the other important thing to mention is just this. The main reason we've actually been able to get back up to speed so fast is that this spring, we were able to bring 3 new leadership associates onto the team. And all 3 of them are students at Case Western Reserve University School of Medicine. And all 3 are passionate about integrative medicine and do intend to practice some form or other once they enter practice. And like a few other students before these 3, we've had student liaisons to the Case student body and faculty. And so we're really excited and happy to welcome all 3 of them. And the new leadership associate who's responsible for organizing and arranging tonight's meeting is here, and she is going to introduce Dr. Bausum and the talk. This is Meha Srivastava, who's M3 at Case. Other than that, if you have any questions, please put them in the chat. And Amy has already put in our link to our subscription list for free. So Meha, take it away.
Thanks, Peter, and thank you everyone for joining. I'm really excited to be able to introduce Dr. Anna Bausum tonight. She was one of my own mentors in my journey in integrative oncology so far and has been really instrumental in the work I've been able to do in this field. So I'm really grateful that she's made the time to come speak with us. So a bit about Dr. Bausum. She is a board-certified naturopathic oncologist at Winship Cancer Institute of Emory University, where she provides integrative support to people living with cancer, either during their cancer journey or long after in the years where healing occurs after treatment. Dr. Bausum combines naturopathic, functional, and holistic therapies with conventional treatments to minimize side effects, support recovery, and improve quality of life. She brings a diverse background that includes training from the Institute for Functional Medicine, research at Northwestern University Feinberg School of Medicine, work in clinical trials, translational science, and national healthcare advocacy. So tonight, she's giving a talk on launching an integrative oncology program at a large academic healthcare institution. She'll be walking us through the process, the challenges, the opportunities, and just kind of what it's taken to build such a amazing and patient-centered system within her own practice. So I will go ahead and hand it off to Dr. Bausum. Thanks for joining.
Thank you guys for having me tonight. And thank you for everyone that's tuning in, and whether it's today or watching the recording. I'm going to work on sharing my screen. That's often the hardest part of doing these types of talks. And I think I was able to do it successfully. Okay. So, as was already mentioned, I'm a naturopathic doctor, a FABNO. But before we get started, and it can be in the chat too, I wanted to see kind of show of hands. Who here has heard of naturopathic medicine, maybe heard of a naturopathic doctor before? Because even distinct from like naturopaths, right? Because there's the kind of structured or unprotected term naturopath, and then there's naturopathic medicine and naturopathic physicians. I see Susan's raising her hand, a number of others. Okay. Oh, wow. More hands are rolling in. You guys have heard of it. Show of hands, anyone have maybe they ended up knowing about these terms or these areas of medicine through personal experience, either their own healthcare journey or through friends or family members, right? Where word spreads. Thank you guys. Keep it coming because it like dings it on my um, little chat window too. Okay, the next slide, if I'm able to advance my slides. It's a tug and pull. A little bit more about me. I went to Emory University for undergrad. And in this space between undergrad and then matriculating to Bastyr University, California for naturopathic medicine, this is where I had my own start in research and ultimately a piece of the pie that pulls it all together. I went into clinical research as a research coordinator. And my immediate boss at that time, Dr. Viraj Master, is now the director for Integrative Oncology and Survivorship. So this has been a relationship that is kind of like, if you will, fermented over time to be part of what we even present to you has come kind of into a program as you see it today. But importantly, naturopathic medicine is a distinct primary care, if you will, specialty, licensed, regulated, not in all states, which is where you sometimes get provider or even patient variability in their understanding of what this means. But we live in times where this is changing. And more states are adopting licensure or some sort of regulation so that more naturopathic medicine providers like myself can show up. Important here, there are a couple of distinct specialties in which naturopathic medicine can be practiced more broadly. Oncology is one of those, and that's really what we'll focus on today. But just know if you're ever looking for a specialist in one of these are also their own websites where you can kind of search for providers in your area or practicing online maybe. All right, going through our agenda is in a couple of different buckets. Foundational planning. Where did we get started, right? Of all the things that need to get done, where do you start? Where, after you've gotten kind of your foot through the door, do you expand and put your resources to work to put like one brick on top of the other and really build something to what is our current state? And then review kind of what are challenges, opportunities, and even kind of my personal reflections on where is there resistance, where are there opportunities for reframing and other opportunities for growth, because it takes a lot of personal resilience, as you can imagine, to kind of have an idea that may or may not be delusional in some people's eyes and bring it to fruition. All right, so if you will, framing the current landscape. Per a CDC survey, patients ask about this, and that's probably what brings us together, right? People are asking in our practice, you're personally curious, and natural therapy use goes up drastically after cancer diagnoses, specifically. In our standard medicine education, if you will, channels, we just aren't taught robustly how to answer those questions. So there's a huge market gap between what patients want to know about, and probably what they're doing at home with or without guidance, and what we're trained to either research or know how to answer those questions. So that's where it comes in then for integrative oncology to work alongside. And this is an important distinction for patients. Every so often, I have people come in who say, Doc, I'm here for the alternative. And that's really when I have to like pull it back and reframe and re-educate that what we do in the integrative oncology realm is patient-centered, good for that, but evidence-based field of comprehensive care that is really around the standard of care treatments. So that can be active surveillance for early stage prostate cancer, It can be recovery from breast cancer treatments, or kind of alongside, whether it's surgery, radiation, or chemotherapy for all sorts of cancer diagnoses, be it rare things like I've had, gosh, it evades me now, but I've had things that are like 1 in a million down to things that 20% of cancer patients have, right? From common to rare. So foundational planning, where do you get started? Even before I started the team, we went out and saw and did work as a program to figure out what is already being done, because where there's a precedent, you can build either something similar or work on improving things. So a market analysis was done of 13 comprehensive cancer centers, including NCI centers, to figure out what's already being done. From there, 4 centers were visited to really experience it, right? Because it's one thing to say, we'd like to start a program. Other people have the program, but where do people check in? How do they get into the appointment? Where do they park? Right? Some of the logistics that you really experience on the ground visiting a place. And then strategic planning. This is the development of a business plan. So this is outside of my realm of expertise, but I'll have a later kind of, if you will, team slide. And that's where you'll get to see our Associate Director of Programs, Almira Kaddick. She comes in with a strong business and financial kind of skill set. And developing a business plan is going to be essential. So if you're going at this alone, whether it's for private practice or in a, if you will, academic medical center, you need to have someone with diverse skills such that you can help develop strategic plans and business plans, because they're going to be something that has to be on file, even if it evolves in the future. And then creating the workforce. At Winship, the directive was utilize existing resources. That was where we started. And that was long before we had allocation for more full-time employee kind of hires. So starting with what you have and getting creative and being resourceful and creating opportunities from there. It's truly where we started. Advance my slides here. With our Associate Director of Programs and Meha's help, they did an internal then, if you will, market analysis, a state of the union of what were provider themes and patient themes for not only their understanding, but their interest in utilization of these resources, should they exist, right? Whether it's to refer on the provider end or to utilize on the patient end. And those are important questions to ask, not only so you get an idea of maybe what to focus on in launching for a service, but also creates opportunities for you to understand where there are gaps in understanding or where there are opportunities to market more, right? Because you can have a product, and if no one knows what to do with it, they're going to be more reluctant to send or come for those services. So you can see here, people know what acupuncture is. People know what massage therapy is. Where probably then me as a provider or us as a program have to do more outreach and education is for patients or referring providers to understand, given this data, what the therapeutic indications or benefits for yoga might be. That gives you this insight of not only where to start, but where to grow once you have different programs going. For patients, if you will, this is something where you really get an understanding of what are people, what terms are they familiar with, but what are they interested in? And out of 100 patients that were surveyed with in their survivorship versus 100 being actively treated, the greatest interest was in massage therapy and acupuncture overwhelmingly, even over kind of wellness services and the breakdown or trickle of other, if you kind of integrative complementary therapies from there. And this is actually work that got published by our program. And I think, Meha, your name is probably on this. You're instrumental in this. So with that data, what did we do with it and where did we start? The first thing we did, and this is part of being resourceful and making a little bit spread a long way, is launch Group Oncology Acutherapy Clinic. You can already see a few things pop out here. Group. So the more economical and cost-effective way to spread one person's expertise to many, a one-to-many model that is cost-effective, but also symptomatically effective. And we'll get to the patient-reported outcomes here soon. And then acutherapy. We use this or coin this term because we're doing a therapeutic application of acupuncture and or even acupressure. So make up words as you go if you need as a way to market. This is where we started. From there, we then added one-on-one patient consultations for me. As numbers grew, adopted a one-to-many model via shared medical appointments to optimize one-to-many delivery and efficiency of this type of expertise, and then started to grow more into collaboration and multidisciplinary team care approaches within the 2 years of launching our first service in acutherapy clinics. So current state. So we mapped it out. We started with existing utilizing resources, right? Then I was our official first hire, and we've grown from there to more recently, within the last 2 or 3 months, actually having 2 patient care coordinators. And this is huge. The most important thing I've learned probably in staffing is, and this is true at every level of medicine. You can have ORs and neurosurgeons, but if they're not people to turn over the ORs, you're not getting anywhere. Our patient care coordinators, our research associates and interviewers are the backbone of what helps the cog turn and us see patients. So it's not just the expertise of integrative medicine providers like naturopathic doctors, yoga therapists, acupuncturists. It's the people who help get patients into the room, patient-reported outcome surveys filled out, data entered so you can report on those outcomes. That's the bread and butter of what will make a program successful. All right, so this integration, our integrative support services, as a summary, are the consultations, shared medical appointments, acupuncture, and more recently, we have launched kind of under an exercise umbrella, yoga, via a yoga therapist. As of May 2023, we actually opened an integrative oncology and survivorship clinic. And it's not just the integrative support services, but a co-presence of other supportive care specialties, including PM&R, so cancer rehabilitation, palliative supportive care services, cancer pain, and in one of our clinic locations, we have cardio-oncology present as well. So it's really this overarching, if you will, umbrella that encompasses a patient's care and well-being during and after cancer treatments with diverse symptomatology. So people don't just come to us with one problem, usually multifocal symptoms that they're presenting with that need care, be it post-surgical pain. I've seen post-surgical fistulas, it's neuropathy and pain that's hard to treat, or things like anxiety, depression, insomnia, and more. So here is kind of a map and how we use up space. I want to point out here, these are multi-purpose rooms that we operate acupuncture out of and yoga out of. So we don't park patients in exam rooms alone. We use a conference room for shared medical appointments and these bigger multidisciplinary spaces for other group encounters, be it yoga or acupuncture. All right, so collecting data is important in an academic medical center, period. Where we started is to prospectively collect patient-reported outcomes to see if we give them an intervention, what changes? And this is not with any inclusion-exclusion criteria, apart from they need to be an established patient with a past or current cancer diagnosis at our institution. That's our inclusion, if you will. We started with would have been December 2021 into January 2022, seeing 6 patients total on our acupuncture service. To now, as of May 2025, seeing 700 patients a month. That's been this increase, nonlinear over time, of seeing people, putting them on schedules, and really graduating. Where we started with the 6, we went into a PT room that wasn't being used that day, unfolded our chairs, pushed the PT stuff aside, and started to recruit patients in the neighboring clinic to say, would you like to try acupuncture today? Because even something like those chairs, the question from an integrative oncology operations standpoint and doing something new, can people get in and out of those chairs, right? How do they come and go out of the room? So even before we had a fixed schedule with appointments that were made in the future, this feasibility of some of the nuts and bolts of seeing someone and conducting an encounter is really where we started, long before we got to 700 patients a month on a service. As of October 2022, that's when our institution launched and converted over to Epic. We started tracking referrals. This is ambulatory orders that are placed from referring providers. And our 12-month rolling average has been 131. In the month of July, we had 161 new patient referrals. And this is not repeat referrals. This is an exceeding amount of growth. You can imagine this type of growth, we cannot staff or hire to pace that growth. So part of what we've had to do strategically is communicate prospectively to referring providers to say, refer early and help us manage expectations for time to being seen, and be very proactive in our communication to patients if they're either needing to wait to get a phone call. This is where having a second patient care coordinator has really helped improve my quality of life because people are getting phone calls quicker. But also then communicating clearly and firmly, but with kindness about the time to being seen. And this is not going to be unique to our integrative oncology program at Winship. This is going to be pretty much the theme if you go to other centers too. I think last I talked to Dr. Donald Abrams at UCSF, his wait list time is 6 months. Right now we're pacing 3 months on average across our services for consults, for acupuncture. Those are the two big ones. But it's something that has been integral and strategic to our growth is the communication bit to referring providers and to patients. So current state, this is a little bit of the numbers. We, since launching December 2021, have done over, at this point, 17,000 patient care encounters, because these are the numbers as of the end of May for our program. I want to remind everyone, this is from starting with one acupuncturist, one naturopathic medicine doctor, and then later adding a second acupuncturist and a second naturopathic medicine doctor. And our last addition for kind of a provider for encounters was a yoga therapist. This is our setup, kind of physically the nuts and bolts of our group acutherapy space. We have zero gravity chairs, baskets for people to put their stuff under. And some of these are just the practicalities of living. So launching and adjusting. The baskets came from kind of, you see people come in with all their stuff and you're like, where are they going to put it? Because they're not going to trip over it on my watch when they get out of the chair. So this has kind of evolved over time based on how we see that environment and patients interacting with it out the gate. Because I think you can think this through indefinitely to try to create something that's perfect out the gate. My advice would be launch, get feedback, and adjust. And some of that feedback is physically being present, witnessing people moving through the space. But here is our multi-purpose room there in Midtown. Here is our wellness center space on Clifton Road. And we operate different hours, but essentially normal outpatient clinic times and expanded over time. The top symptoms we see patients come in for based on their PROs and no sort of selective screening for inclusion is cancer-related pain across the board. And then, kind of coming down the list, fatigue, neuropathy, and at this time that we did this data capture, we're seeing a large head and neck survivorship population, which is why xerostomia is on this list. The reality, head and neck cancer accounts for less than 15% of all cancer diagnosis, so there's a little bit of a heavier weight on this dry mouth xerostomia in our data set. It gives you a good idea of kind of the breakdown of people coming in with multiple symptoms. Here is a linear kind of, or non-linear, but bar graph of numbers seen in acupuncture alone per month over time with our visual distinctions of the stages of growth. The red, 1 day a week, half a day, 2 to 4 days a week in the light blue, graduating to 4 days a week of almost full clinic days, and then going, on the yellow to 2 acupuncturists operating 5 days a week. Shared medical appointments now. I did my initial training with Dr. Jeff Geller at the Institute for Integrative Group Medical Visits. They have a Zoom training that I highly recommend. It's a way to demystify the one-to-many model, and that's where we started. Over time, it's evolved, but now we run disease group-specific modules for these shared medical appointments, and rather than making it one long experience, we break it up over several weeks, and this has all been patient feedback. It's a way to not only optimize care delivery, but be efficient from a provider standpoint and help people feel engaged in a cost-effective way for their care, because they're reducing kind of visits into the clinic, but able to engage in kind of peer environments too. And this helps engage further adopting these lifestyle changes that are often talked about in these types of settings. I think it's data that comes out of the Cleveland Clinic that has their shared medical appointments or group medical visits in their functional medicine program. Patient-reported outcomes have statistically significant kind of improvements that exceed just what individual care alone can provide. So there's something therapeutic to groups. And this is a way, in my opinion, to also reduce provider burnout. I can much more mentally and emotionally effectively see people in a group than what it would take for me to apply that same kind of care to the one-on-one model alone. And this is a way for visually over time. We don't have a time marker for when our second shared medical, rather our second naturopathic doctor joined us, but it would have been January 2024. This time marker right here in the middle. Before that, I carried all of this alone, so it's been tremendously helpful to be able to give someone more patient care and have a little bit more breathing room for the operation standpoint of things, and when it comes through the lens of kind of program development and growth. Yoga. We do yoga in a group setting. We have chairs in the room, we have mats and all the kind of accoutrements to carrying out a yoga class. This comes as a generous loan from the general surgery program. The general surgery program, this is their staff yoga therapist or yoga teacher, their equipment, and they are now as a program operating entirely online. So this was, these were props, yoga props, the mat, the blocks, the bolsters, blankets, and straps that were just in storage. So being resourceful, creative, curating, asking questions, talking to people, that's how this came about. And as recently as March of this year, we went from 1 class to 2 and started to collect patient-reported outcomes. So those are now just trickling in, and we schedule people. We try to schedule people in kind of 4, 5, or even 6-week sessions at a time, so they have this regular continuity. And we have people who have never done yoga. I'm very proud to say that the people who find the most benefit from this are kind of the people you probably wouldn't see in your standard yoga studio. It is men over 40, African American men, people with chronic pain, insomnia, fatigue. They're all moving, breathing, and flowing in accessible ways together. And that's what I describe yoga to be. Less about touching your toes and reaching your arms over your head. It's about breathing and moving in a way that's accessible to that person, even if it looks different from left to right. I taught yoga through my time in medical school at Bausum. I encourage patients, especially if they have movement limitations, to actually close their eyes. Maybe they're able to reach their right arm high and their left arm have restrictions. With their eyes closed, how can they breathe a sense of equilibrium from left to right so it feels the same, even if their reflection mirror is different? So as you kind of interface and tell people about the benefits, even if they're doing yoga online or YouTube or go to their local studio, how can they adopt it and feel more encouraged? Here's an example of the patient-reported outcomes we're rolling with in our program now. We have twofold. Promise 29. This is a 10 inventory itemized questionnaire that has several different domains of symptoms that can change over time. And it comes out of the NIH toolbox. And then we have MyCaw, the Measure Yourself Concerns and Well-Being. This comes out of resources in the UK that lets people write in their concerns. The difference here, people, and this is just my perspective, people will rate their physical function as, let's say, without any difficulty, but then write things in here that really help you understand that answering these toolbox questions doesn't always reflect or capture what someone is burdened with. And it might be physical function, but the way they use their own words to describe it really is a meaningful way to measure well-being and change over time. It's rated from 0 to 6, and a delta of 2 offers meaningful change, something that's averaged as aggregates. But this is something that if you feel your patient-reported outcomes are washing out the effect you're seeing with your eyes from a clinical standpoint, we had to ask ourselves, is there a different PRO we can ask that offers patients a more meaningful way to report the changes they're seeing in themselves? Let's see. Here's a breakdown of the patients we see, and this may reflect everyone's practice. Generally, wellness services in any part of community care, naturopathic medicine, functional medicine practices, or just in the community as a whole, women utilize these services more. Breast cancer is just a large percentage of the pie for cancer diagnoses, period. So we see just over 50% of breast cancer patients alone. The rest is really a smattering cornucopia of everything else through the NCI designated cancer center we operate in. And given that we're in Atlanta, can really faithfully draw kind of a 6-hour perimeter around Atlanta. And that's the patient population we're drawing from, which is why we've really emphasized some of these virtual programs, even like shared medical appointments, to lower the barrier for entry for patients to participate and receive benefits from integrative medicine. So effectiveness, here's some pilot data of 151 unique patients, just looking at their PROMIS 29, a mix of diagnoses, stages, and treatments. So that was not something we looked at. Our inclusion for the pilot data was just having 8 or more acupuncture visits over a period of, just say, regular 10 to 12 weeks. So not just over the period of a year, coming in regularly. Through these patients, we saw statistically significant decrease in anxiety, depression, and fatigue, and an improvement that met statistical significance in their social participation. Polysymptomatology, this is a way for us to, through a heat map or spider plot, to show changes via our MyCaw, and the concentric reduction of this kind of spider web figure in the middle is a reduction in symptomatology as well. So symptoms improving no matter what patients are coming in for. And this is the kind of 151, and the number goes up here because we had more MyCaws filled out, but of that patient population receiving 8 or more consecutive acutherapy visits. Current project that's grown from there, so not just prospectively collecting PROs, but we have more formal IRBs to include. We're actively enrolling and just got started in AI-associated arthralgia, specifically in Black women after they've finished their early stage breast cancer treatments. And we randomize patients to either placebo, kind of a group, I think they do some sort of support group meeting regularly, or acupressure or acupuncture twice a week for 6 weeks, followed by weekly for another 6 weeks and more. So writing for grants, recruiting, this is all teamwork from more than just people that see patients. So really thinking about, as a program grows or you get things started, do you have strategic partners that you can work with? Because everyone has their own areas of strength or ways that they are able to grow and kind of build on their own success. An example here is this R01 proposal. This bladder cancer study came from work done. I see that Susan Belieber's here at University of Washington, Fred Hutch, in bladder cancer in an earlier phase, and now we're a strategic partner in applying for phase 3. It's not something that you have to create from scratch, but working together has been instrumental for us. So here's barriers or opportunities for growth. The value of these services is hard to measure. They are a market differentiator, meaning people may come to that cancer center more likely than other cancer centers in the area. There's data suggests it decreases utilization for emergency room visits, maybe even messages between medical oncology appointments or other more standard medical encounters. This is work that's incredibly labor intensive. We're working on currently, but involves mining the records, having people referred, never seen to integrative oncology versus people who followed regularly, and then mining that information over time. An additional barrier is reimbursement. These are services that are either expensive out-of-pocket costs or hard to reimburse because they lack consistent or reliable insurance coverage. And the way we have structured our program is we provide the services as a courtesy free of charge for people who are established at Winship, but that does mean we have to cut them off at some point. So especially in our acupuncture clinic where we're not meeting demand left, right, and center, we discharge people after 12. There are extenuating circumstances where we extend people beyond that. But really that messaging of this is something that we now know helps you, hopefully take that confidence and then establish with someone in the community for acupuncture. So the messaging we've had to go with, given that we're not charging at Winship. Growth of referrals, while good, I've mentioned some of this, also has downsides because as referrals grow, you're not able to necessarily linearly track growth of available appointments or providers to see these patients. So we've really had to be on top of messaging, creating home resources. This is where our website now features under AcuTherapy videos the program has made for acupressure, just ways to give people things to do to help themselves while they wait to be seen. And then the resources, right? It is always ongoing conversations about institutional support, resources, space, and this is not unique to integrative medicine services or integrative oncology. There are turf wars for OR space in every hospital too. So that's true across all spaces in medicine. And it'll be something that as part of establishing and growing a program are realities to face. Then for additional opportunities for growth, just the integration across all care lines. The most common negative feedback I get is, why have I not been referred sooner? It might be that your provider didn't know that this existed. It's not standard of care. And Emory is a big institution that I can't account for everyone knowing that we exist. So this is just something to be aware of. Our program has not done any outreach ever, I should say marketing or advertising. We're just now at the point of doing a little bit more outward facing marketing so that people are able to have search results on Google or different things come up. But we did not start with that. It's word of mouth only. Funding. So this is always an ongoing conversation of engaging philanthropic organizations or opportunities, facilitating connections between different programs, donors, or research grant funding, and then billing. As licensure improves or evolves over time, whether it's for naturopathic physicians or acupuncturists, this will change. But we have had to get creative in exploring things where E and M coding or billing, sub-billing, or even just effort tracking with unique non-billable codes needed to be implemented so that we're part of the larger conversation in terms of productivity for an institution. So personal reflections now that I'll end with. You will encounter a tremendous amount of resistance. You're going to be told no, can't do, delusional. You have to take risks and be resilient and turn your no's to yeses and create opportunities for yourself that give you that foot in the door, a place to start, to take what you have and be resourceful, launch, gather feedback, whether it's from patients or with your own eyes, and adjust from there to then over time facilitate little by little, again and again, that growth. With that, I want to thank you guys for being here tonight. I know you guys probably have incredibly busy schedules. This is a little bit of a snapshot in our Midtown clinic. On the far left is our yoga therapist. Both of our acupuncturists are pictured here, as well as our associate director of programs. You kind of saw this in the breakdown of the team on an earlier slide. And with that, I want to stop my share and answer questions. I'm just going to stop my screen share so we see each other better.
Okay. Thank you, Anna. I'd like to, I mean, there are questions in the chat, but I'd like to just get the ball rolling with a couple of things, if you don't mind. Can you say a little bit more about the difficulties that you ran into when you were trying to start the program up? I mean, you've talked about this incredible growth that you've had. It's like, seems to be growing itself, which is fantastic. But what about the challenges part of it, the early resistance, funding challenges, all those kind of things that we had alluded to? So that's one thing I just want to get more of your perspective on.
The challenges are diverse, and some of them are, or often they're not adverse, but at least at Winship, there's not a handbook of how to do things and get things done. Sometimes it's knowing who to ask or figuring it out with a can-do attitude, how to do something for yourself. So we started with maybe me as a provider, but no appointment types, no schedules. We had space, we had a time of the day, we could recruit patients by word of mouth, but there was no appointment type or schedule to park everything on. So we started with just making verbal agreements with people about when they would come back next week, a small group of people. And over time, asking the right questions, calling the help desk often enough, opening tickets, those tickets getting closed, calling back, opening it again, to develop even the tech pieces of seeing someone. So those are some of the challenges of figuring out how to do this and not waiting for anyone to come in and help. Then there are just space issues. When we opened our Winship Midtown space, of the entire building, and it's 18 or so stories of disease group specific care, kind of on a 1-2 outpatient, inpatient, outpatient, inpatient, we're the only floor that wasn't copied and pasted from somewhere else, meaning there was not a clinic manager coming over from a different building, or all the different little operational pieces that help support launching, outfitting, and starting a new space. So before the open house, was taking a Swiffer mop and Clorox wipes and cleaning up construction dust to get things done, and parking contacts in my phone, like environmental services, Vinny in the bullpen for the keys, and on the list it goes. So taking on this kind of Renaissance man list of duties just to get things done and figure out how to do it before anyone came to help has been part of it too. And then you can imagine there are people from an academic standpoint that are non-believers. That is also a challenge. I draw inspiration. I listened to one of Dean Ornish's talks a couple of years ago. He said, if you're doing something good and you do it well, you do it long enough, everyone will come around. So it's been this focus on staying in my lane, setting up good systems and good processes, and doing all the different things to help put miles on the odometer, not only for seeing more patients, but ensuring we're collecting data, we're contributing to research, and figuring out ways to grow that are sustainable, that aren't just this linear attraction of demand and hiring more.
Did you run into, though, people in your institution who said, you shouldn't even be doing this, this doesn't belong here, and things like that at the beginning? Did you run into that kind of resistance?
It happens, and that's where having the right mentors or strategic partnerships in leadership are invaluable. It still happens. I've been in this role now since we wanted me to start fall of 2020. It officially started fall of 2021. It happens, but I think that's true. We have creative differences in all sectors of medicine, whether it's integrative or conventional, and just seeing people well and safely and doing it. That's kind of the path we took.
Okay. Amy or Meha, do you want to take some questions from the chat?
Sure, yeah, thank you. So there is a question from Eduardo in the chat. read it out loud. I'd love to learn how to get a good foundation in integrative oncology. I mostly focus on obesity medicine, but I was wondering if there are any courses, books, etc. you'd recommend.
Courses, books. There is, so for medical doctors, there's some training through the Andrew Weil Institute at University of Arizona. It's a fellowship in integrative medicine. I don't have the chapter textbook on my shelf over my shoulder, but there are a few naturopathic medicine textbooks as well as a David Rankel integrative medicine textbook. And the David Rankel textbook is what the the Integrative Medicine Fellowship is blueprinted out of. They are great ways to get started because the chapters in there, I think, are pretty comprehensive for the major disease group spaces in cancer. I think there's a colorectal cancer, a lung cancer, a breast cancer. There's not a prostate cancer chapter, but then a end-of-life care chapter as well. And that gets you a good start. The Oncology Association of Naturopathic Physicians, or ONC-ANP, is a good resource as well. They have published textbooks, they do webinars, CME kind of talks, as well as have an annual conference every year as well. And that's a way to get more information, but maybe build strategic partnerships for even referring or co-managing patients. I'll let you guys steward the question asking.
Okay. Thank you. That was great and helpful. I'll ask another question from Dana Park in the chat. What is the average time a cancer patient will continue to access your clinic/services? Do you send them to community providers later in survivorship to decompress your clinics?
The average time, that is a good question overall. I don't have a data-driven answer apart from kind of my clinical sense of things. It can be as little as just a couple of months because it's end-of-life care and we're helping co-manage cancer-related pain from not only from the palliative supportive care perspective for therapies, but then non-pharmaceutical treatments, acupressure, acupuncture, naturopathic medicine, all the way to years. There are patients that are on our service that have been there since we started. And so this is December 2021 then. There, more and more people are surviving cancer as a disease and then living with the, I hate to say comorbidities, but the ways their treatment affects them, either visible to the naked eye or invisible. And this is not something that we always have a good prescription medication to either manage or cure. Peripheral neuropathy is one of, I think, the prime shining examples in this space where we don't have good answers. So we see people for the long term, and it may get them better and they head home on their merry way and we never see them again. But for the most part, we see people over time, especially the metastatic breast cancer patients. And this is something where even if they're not able to see acupuncture indefinitely, weekly, forevermore, they're certainly present regularly on our naturopathic medicine service or in yoga.
Okay, great.
Meha, you can keep on like scrolling through the chat and read comments and as well as questions if you like.
Yeah, so the next question is from Laura. How is the program paid for? Are you able to bill insurance for any of your services? Are patients billed?
We do not do any billing or insurance reimbursement right now. And that is both from a operation standpoint of where do you start and how can you grow from there? Because it's complicated then for maybe pre-certs or billing and what's being rejected. And our program from Jump wanted to do something that was accessible to everyone, independent of financial means. They only needed to show up, whether it was virtually or in person. That's been something that we've championed as standard of care, free of charge. Leadership is in support of that, and we're written into even objectives that help the NCI designated cancer center maintain that designation. There are ways that this is kind of being tracked over time. What are the initiatives? What are the ways that these initiatives are meeting certain benchmarks and growing in their goals over time? Integrative oncology is part of those line items. And it's important at this level, we're not the only ones not charging. Our head and neck cancer program, their dental oncology is not a separate billable service. It is part of the care they receive there. The same is going to be across the board of other disease groups for nutrition, social work, or some of these other very key supportive specialties that help people through the entire process. So that's kind of where we live now. And because we haven't chosen this billing model, either fee for service or insurance, it's limited our growth, but we carry on despite that. And I want to comment here. Dana Park says, SIO is coming out with an integrative oncology textbook as well soon. I co-wrote the chapter on surgery. So you guys should all get that textbook. I think I might be on the chapter for soy too.
That's really great. I will look out for that. I think that's much needed.
So the resource question, pick up that SIO textbook soon.
Okay, so the next question is from Lisa. They ask, so you mentioned the Promise 9 and MyCaw surveys. Are there any other patient-related outcome measures utilized in your research?
Those are the only two we're currently using. There are other measures implemented by the institution. It's a distress screening that's a little bit shorter than our Promise 29. It's a 9 or 10 item inventory that also, I think, does a screen for malnutrition and a couple of other distress signals. And that's what we're hoping to use as kind of our never seen control for changes of symptomatology, because inevitably across the board, things like ECOG or the grade of symptoms alone as they're documented in their medical record are just too variable to be using to report on.
Yeah, just to add a little comment, I remember starting to use the MyCause and being really honestly taken aback by how much better those surveys capture the patient symptomatology as compared to the Promise 29 or some of these very kind of limited surveys where
Validated, but not as comprehensive, right?
exactly. So comprehensive being the key word, like patients aren't able to really tell you in these surveys what they're experiencing, but their own motivation for coming to that acupuncture appointment or changing their nutritional habits, that is really the progress that we need to track in larger integrative oncology programs.
Yeah. I'll give an example here to illustrate what Meha just said. We had a over 60 years old, I think Southeast Asian gentleman, maybe Pakistani, I can't remember, but a head and neck cancer survivor patient with significant comorbidities, including diabetes, that had his cancer treatment be radiation up front. He was not eligible for the cisplatin due to ongoing medical comorbidities and then proceeded on to surgery. He came to us over 6 months after the completion of his treatment, his neck swollen out to here, unable to talk, unable to drive himself to those appointments or move his neck at all, and in a wheelchair due to non-healing wounds on his feet from the diabetes. His 12th acupuncture alone as a monotherapy, he walked in without his walker. He was on a cane, but not in a wheelchair, not in a walker, saying he had driven himself to that appointment that day. He was able to talk to his family in Pakistan, now I remember, and eat the food his wife was cooking for him at home again. His Promise 29 had no change. No change.
Yeah, I remember him. And yet his the markers of his quality of life as defined by himself would have been so different. So yeah. I
So
think
this launch and adjust.
yeah. I think it's also important to just highlight that data is really what drives systemic support for different integrative programs, and especially in larger healthcare institutions, in order to get funding, in order to get the credibility to get referrals, you need data to show that what you're doing is helpful. And so selecting an accurate and representative patient-reported outcome is one of the biggest challenges for any integrative program. And yeah, just really important to think about. Okay, so I'm going to move on to the next question. Susan Starr asks, would you please explain how the group acupuncture works in terms of length of appointments? How in-depth is the acupuncturist intake or eval? Does the therapist only focus on one issue? Is acupressure done during these group visits or just acupuncture? I can repeat parts of that if...
No, I understand the question completely. So we have built a schedule where someone arrives every 15 minutes for a 30-minute treatment. We have a selection of protocolized treatment points that are associated with different concerns. So a patient may arrive or present with multiple different concerns, but we tend to only accept concerns that are cancer treatment related or validated. We're not, and people will write everything on those little sheets. We do have an intake form that then the acupuncturist is writing the points on and taking their own notes on as part of kind of documenting the care before they're then put into the medical record. But people will write right eyelid twitch, left pinky toe pain. Those are not the things we're treating. We then redirect or kind of help counsel. But a lot of that intake of symptoms is done before the person is put in the chair. The chair is really, once they're in the treatment chair, we try to treat it like someone who's already been prepped for surgery, like anesthesia has done their thing. They're ready to go for this operation to actually start. So that's kind of how we run our acutherapy clinic. Did I hit all points of that question? Oh, we do 12 visits.
I
12
think
weekly visits.
maybe a little bit more on how in-depth is the actual appointment. So I know, people are in a shared setting, they're not like undressing or anything. So what does that look like?
We have people come in loose, comfortable clothing. As part of launch and adjust, I started saying that, and ladies were showing up in their caftans and muumuus. Separates are preferred. We access peripheral points and ask them to wear clothing where we can negotiate the sleeve, the hems of their pants, and even kind of, especially if they have low back pain. My cats come to join me, so if you see a tail wagging, it's not mine. Even for low back pain, we just do tangential needles for some local points for back pain. So having those separates of top and bottom really is invaluable. And we focus on symptoms and protocolized treatment sets. Not to say an acupuncturist needs to use all of those points, but it puts these bounds of what peripheral points we're using based on the available data to say these are effective treatments or protocolized applications of acupuncture, and go from there.
Okay, great. I think that answers all parts of the question, but Susan, if you have any follow-ups, please feel free to add it in the chat. Next question is from Kevin Brown. Do you think your ND background, as opposed to being an MD, has been an advantage in terms of establishing a new type of service, or do you think it has made it more difficult for you?
Naturopathic medicine and the MD, I was the first naturopathic doctor Emory Healthcare had ever hired, period. And that'll come with unique challenges. So it's been an advantage and a disadvantage. There'll be people who feel that what I do is witchcraft. And there's people who greatly appreciate what I do and everything in between. I think it comes down to coming from a place of non-ego and showing up with confidence in the area of expertise you represent and really using the right language. Because if I were to walk around and say, I'm harnessing the healing power of nature, that's not going to land. But saying that turmeric can cause problems and we avoid it as a recommendation for narrow therapeutic index drugs, CYP3A4 metabolism is contraindicated, may reduce the effectiveness of tamoxifen. That's the language you need to speak for success. So I hope that answers Kevin's question. I think there is plus and minus, but knowing your audience and showing up with confidence and competence are paramount.
Okay, great. Thank you.
Mhm.
This question was already touched on, but I'll just go ahead and ask it again. Is there any service that is covered by insurance?
There are services in different states that may be. Naturopathic medicine in the state of Washington has been licensed for 100 years. They are insurance billing primary care providers or in other specialties. The same may be true for acupuncture. It's going to be very variable by state. In the state of Georgia, we're more limited. And because of those limitations, we've decided to forego any billing and just provide the service so that people can benefit. It's going to be very, very variable. One of the few diagnosis codes for which acupuncture can be covered, and this can be insurance provider specific or variable, is low back pain. So after we discharge people, especially if they have low back pain, we encourage them to follow up with their insurance, because there are insurances that will provide it for certain CPT codes, maybe just 12 a year. It's really, the opportunities are out there, but people have to start asking, and it's variable.
Okay, thank you. Someone or Susan asked again the name of the preferred survey. I threw a link in for the Meaningful Measures website, but it's called MyCall. Fiona asks, what does the future look like for your group?
For the group, more research, less growth of available appointments, more resources behind research, if you were to ask me. Like, people will have to wait because growth will be in data and research.
On that note, since I know there's some medical students on this call and people interested in research, you did kind of share what projects are going on right now in the program, but what is needed in terms of research? Is it like more hands on deck or is it more ideas?
I think one of the ways as a medical school student to be involved in research is ways to give back time to research programs. So figuring out who in your area is doing some work, and it might be doing survivorship follow-up phone calls, calling people out of existing databases and figuring out, are they still alive from their kidney cancer or have they passed away? It's the things that are very time consuming that as a medical school student, whether you're an M1 or an M3, are ways to curate those relationships and find mentorship opportunities, because you have time where other people do not. And this was probably your experience, right? You did things that were time intensive, maybe not overly complicated, but tremendously helpful over time.
Yeah, definitely. And I think division of labor is just a key to getting any research done. So having all hands on deck is really important. Lisa asks another question. Do you offer any infusion services such as IV vitamin C?
That's not something our program is doing. So higher level integrative care, such as is maybe done in private practice settings, we're not doing at Winship. Maybe in the future on research clinical trials, but not something as part of our open scheduling services.
Okay. Susan asks, for your group visits, do you do one-off integrative topics or do you do a series of visits per topic?
Twofold. For people newly referred, and this helps reduce the time to being seen because you can always see more people in a group, we do series of topics. Example, one of the first things we launched were shared medical appointments for breast cancer. We divided it up into people actively receiving cancer-directed therapies versus people maybe on maintenance or long-term survivorship type of trajectories, and then broke it up. First, it was one long talk, feedback, broke it up into 3 talks, and we go through lifestyle. Nervous system directed things, acupressure, mindfulness-based stress reduction, yoga, as things in that bucket. And then lastly, supplements. We do supplements at the end strategically because we want people, you cannot out supplement bad habits in 1 and 2. And people can get overwhelmed by that topic of kind of going through and saying, like, skip this or think about ginger for this. And then it leaves them kind of tail spinning for the other sessions. And then we do one-offs in either follow-up or other disease group models. And the best way to establish your groups over time is for your group to actually decide on what the topic is for next time. And have this community sourced input of what they'll talk about. So we don't do maybe one to the next session, but at the top of the hour, I ask people, what do they want to focus on today? And then I start to pull out threads and kind of interweave it so that people feel that they're being talked to very specifically, but they also have peer group support in those aspects as we go through the hour.
Thank you. Follow-up question on that topic. Have you seen, so obviously the topics around cancer, whether it's during cancer care and the ongoing symptoms that patients are having or the symptoms that they're carrying with them for years after their treatment, they can be very personal and like really hard to deal with and hard to share with other people, especially. So how has that played out in terms of patients actually being able to be completely authentic and ask for all the help they need with other patients present? And have they actually like ended up supporting each other and it being good to have a group?
So those groups, I acknowledge that at the beginning. I say, this is probably unlike any other encounter you've had. We typically meet one-on-one, never in the group. I say, from a provider perspective, you guys are very likely all thinking about the combination of a few things with a lot of overlap. And that data suggests health improves in the group setting, exceeding what we're able to do one-on-one alone. So there's medicine in community. So I go ahead and frame it from the top. Say maybe not everything. We have one-on-ones available too. And even our in-person space for our shared medical appointments has an attached exam room. But people really rally in that space. They support each other. Once one person kind of opens up, the rest do too. And this is something that Jeff Geller in his training kind of helps you even get skills around. How do you get people to talk? How do you get people to engage in this format? And one prime example is I was just abroad 2 weeks ago and I got a phone call. We were starting kind of week 1, 2, 3 of this breast cancer series. And our patient care coordinator was like, oh my gosh, a man's in the group. What should we do? If you do work at high volume with efficiency, there will always be errors. It's about identifying them and figuring out how to proceed. And I said, give him a call, let him know where he's going to show up, and let him decide. He showed up, and he's the most engaged, and everyone is rallying around him and thinks this is the best thing ever. So it's just as time will tell, but being honest with people and upfront so that they even like know or have words or validation for if they feel uncomfortable, that's okay. We're going to do it anyways.
Yeah. Okay. Thank you. I think from my experience as well, it's also about how you frame it to patients because some patients will hear the word group or community and think that you're talking about like a support group and be vehemently against that. But once you kind of frame it as more of like, this is a really efficient way to deliver your healthcare, then it's obviously received much better. So I think you make really good points on that topic. We have another question from Liam. Do you envision that insurance companies start covering integrative oncology services?
I think in the future it's there. I drew my inspiration or even where I ended up from, I was born and raised in Germany. This stuff is all part of the standard medical model and has insurance coverage potential. Here, I think we're a little bit behind those times or that vision, but good data, expanding licensure laws from state to state, then insurance companies come around.
All right, thank you. We have a question from Emily. How would you envision the nursing profession to impact integrative medicine, its growth, as well as its outreach? And this is from an oncology perspective as well as in general.
I think nurses are invaluable in all of this. We don't have one on our team yet, but it's a way to just get more expertise to patients, whether it's for encounters or in between encounters. Because people will send messages, have questions, needs for phone calls that one person alone can't do it. And I used to do it all alone, including make appointments, send Zoom links, call people. So the more, the merrier. I think there are programs on the integrative side that employ nurses right now at cancer centers. We're just not one of them yet, but I think it is a next step and a feasible way to grow and diversify support giving to patients.
Okay, thank you. Those are all of the questions from the chat. Peter,
Yes, could I just interpolate a little comment here?
Peter, you're muted.
Okay, I don't know how that happened, but now I'm here. No, I just wanted to interpolate a comment reacting to something you said much earlier in your talk about community awareness and also just awareness of your program within your institution, right? So what I wanted to say is, you know, here in Cleveland, we have two big hospital systems, and they both have long had integrative medicine programs and departments. I've actually had the chance to work at both of them. But at the Cleveland Clinic, there, at the time I was there, it was just the Center for Integrative Medicine. And then there were some other programs like Lifestyle 180. And, you know, so there's, I mean, the titles have kind of changed. And now there's a Center for Functional Medicine as well, which is distinct. And however, at university hospitals, originally, it was something called the Connor Integrative Medicine Network, not department, but network. And that was due to the influence of the inestimable Françoise Adan, who was the head of that program until she just left very recently. And just, I think, a brilliant leader. And that her perspective was, let's not call it, I mean, she didn't say this explicitly, but it was like, let's not call it a department. Let's call it a network, because she wanted it to have an outreach to every department in the hospital. So it wasn't just an isolated department that other departments might or might not be aware of. It was part of this whole network. And I think because of that, and now it's called Connor Whole Health, but I think on account of that initial view of let's create a network throughout the system, that there was like a much better response throughout the healthcare system to the integrative medicine program than I saw at the Cleveland Clinic, where it was just department. So I just want to throw that out there, maybe to think more network wide for your program, and that might have a better outreach success with both the university system and even with the community. Just my thought. Okay. Does anybody have any other questions or comments? Complaints? No?
Thank you for having me tonight.
Well, thank you for coming and being here and giving the presentation. We did have Kevin is just texting right now. Kevin and Dana Park are both members of the IOWG, and I'm so glad that both of you were able to make it tonight. So all I'd like to say besides thank you, and I'm glad everybody who could make it, those who couldn't but signed up, of which there were many more, will be able to hear the recording, and I will send a note out to everybody who is on the registration list to let you know when the recording is available. I mean, it's all, it's all on the AIHM YouTube channel, which is AIHM slash, what is it? YouTube.com/AIHM global. So all that'll be available in pretty short order, and you all know about that. And the last thing that I wanted to say is just looking ahead a little bit, programs we have coming up are in some cases areas that we've never had any speakers or panels about. And I'm really excited about next month's program, which is going to be on integrative optometry. We've never had any speakers about that, and we have two of the best coming up. Mark Grossman is an optometrist who's famed for his work on nutrition for the eye, clinical nutrition for the eye, and vision therapy, and body, mind, spirit approach to vision. So I think it's going to be really quite a cool presentation. And that's it. Meha, thank you very much for doing your part and putting the talk together, and also for moderating the chat.
Thanks, everyone. Thank you.
Have a good night.
Have a good
Bye-bye.
night.
Good night.
Good night.